from Dr. Rajeka Lazarus, who's an ID physician at the University of Bristol, who is going to talk on the topic of co-administration of routine adult vaccines.
Good evening, everyone. So thank you for the invitation to speak. My name is Rajeka Lazarus. I'm an infectious diseases physician based in the UK. And over the next 20 minutes or so, I'm going to be speaking to you about vaccine co-administration in adults. So this is a topic that I've been working on for the past couple of years, and one that I think is important to help maintain and improve vaccine uptake in adults. So some of you might be wondering why this is an important topic, especially when the current adult vaccination schedule that you can see on your right is quite limited in comparison to the childhood immunisation programme on the left. However, the childhood immunisation programme has been built up over the past 40 years, and as everyone in this room knows, it's been one of the most effective public health interventions to date. So, adult immunisation programmes are more complex than I've just presented here on the screen. In addition to older adults and vaccines for in pregnancy, we also have vaccine programmes for those who are at increased risk of infection, either due to occupational exposure or their own health problems. And as we continue to have an ageing population and an increase in the prevalence of chronic diseases such as diabetes, then the prevention of infection has the potential to have a big impact on morbidity and mortality. And there's certainly been increasing recognition of the important value of adult or life course vaccination. The World Health Organization 2030 strategy that was published last year had a focus on lifelong immunisation and the importance of evaluating how we deliver lifelong immunisation and how we integrate it within our current delivery models in order to maintain and increase that vaccine uptake. So I suppose kind of one of our first challenges with adult vaccination is really the delivery of the multiple seasonal vaccines, and we need to think how we do this. So the flu vaccine has been delivered annually for several decades in high-income countries, and that alone has taken up quite a lot of resource. And uptake, I think we'll all agree, is less than ideal in some years and in some groups. And over the past 2 years, we've had the added challenge of incorporating COVID-19 vaccination, and seemingly kind of on an ad hoc basis as the pandemic has really emerged and evolved, but it doesn't look like COVID-19 is going anywhere in a hurry, and that repeated vaccination is needed to maintain protection. And then we have another important seasonal virus, which is respiratory syncytial virus. And as the name suggests, this causes respiratory tract infections, and in temperate climates, it causes regular epidemics. That in the UK, it started in October, lasted 4 or 5 months, and peak over the winter. So most of us in this room will be familiar with RSV being the cause of bronchiolitis in infants, and most adults will experience mild cold-like symptoms. But in the US, they report 60,000 hospitalizations a year because of RSV and up to 10,000 deaths. And these data from China compare the complication rate of RSV in adults and in children. And what you will be able to see is adults are more likely to have organ failure secondary to RSV, and this is associated with longer hospital stays, critical care admission, and a higher mortality rate as well. So in light of all this, the RSV vaccine landscape has really been building up over the past few years, and you can see it's a highly fertile landscape, and it's been rapidly changing over the past few months, with the first RSV vaccine that's been approved and read out from phase 3 trials that report vaccines that have 80% efficacy in preventing severe disease. So this is potentially another vaccine to add to our seasonal vaccination programme. And so how do we do this? So kind of co-administration has been kind of discussed in the past 2 years in the context of COVID-19 and flu vaccines. And this became World Health Organization policy in 2021. And I just want to draw you kind of to that bullet point that I've circled. So it's policy for reasons that I'll come on to discuss and help us deliver the vaccine. But it's also kind of that co-administration could help be a prompt for another vaccine. So if the focus is on COVID-19 booster, maybe it could be a prompt for influenza vaccine. And that's the point that I'll come back to later. So these policies are really based on studies like the one that I presented at this conference last year, which show that the differences in reactions between having COVID-19 vaccine alone or given with flu did vary by age group, but when there was an increase, that the increase in reactions was mainly mild and moderate. And since that time, we have more data, and these are data from the US, and this is from a study where people join and they can report their own side effects on a mobile telephone app. So this is really pragmatic, real-life data, and unlike the early studies, this is data with the booster vaccine as opposed to kind of with the first or second dose of the vaccine. These were collected between September 21 and May 22, so really when the kind of the first booster doses were rolled out. And they have really big numbers reporting, so just over 90,000 people who had co-administration of flu and COVID, and a lot more people who had the COVID-19 vaccine alone reporting their side effects. Most of the people who reported side effects were aged between 50 and 74, with less than 10% being over 75, but perhaps that relates to this type of methodology. And the most common reported reactions, whether you got 2 vaccines or 1, were fatigue, muscle ache, and headache. And these were mainly mild and moderate, started the day after vaccination and were self-limiting. And when rates of vaccine reactions are compared, you can see from the odds ratios here that there is an increase when you have the 2 vaccines together compared to 1. And interestingly, there's an increase in injection site reactions as well. But there's no detail of whether these vaccines are given in one arm or 2 arms, but kind of most commonly, I think you get a vaccine in each arm. So that's interesting that you would get an increase in injection site reaction because of a vaccine in another arm. In terms of the systemic reactions that I really kind of mentioned, there was a slight increase. And I suppose in terms of kind of what's important, how it affects our activities of daily living, which are kind of classified as kind of grade 3 reactions, I might refer to again, there was kind of a slight increase with the Moderna flu vaccine combination as well. But importantly, kind of most people, if they did experience side effects, it had to be stressed, they were mild and moderate. So the other important thing about giving 2 vaccines together is to make sure the immunogenicity is preserved. And this is a graph from the study that I led last year, where we measured the spike protein antibody after COVID-19 vaccine alone or given with the flu vaccine. And on this graph, what we have shown is the ratio of those antibody concentrations. So anything to the right means that the antibody concentrations when you have the vaccine given with the flu vaccine, and on the left is when you have COVID-19 vaccine given with the placebo. And the big black dots are the actual kind of the means, but what's really important is kind of the confidence intervals, and the upper confidence intervals all cross that dotted line kind of in the middle, and the lower confidence intervals are all well above that blue line that I put in there, and that blue line is the kind of cutoff imposed by the WHO to kind of determine whether one vaccine or vaccine combination is inferior than another. So what we can say is that even if absolute antibody concentrations may be kind of lower, there is a variation, and then not significant in relation to this WHO cutoff. And importantly, when co-administration was embedded into one of the phase 3 COVID-19 efficacy trials, there was no reduction in protection. So hopefully I've convinced you that kind of to date, COVID-19 and flu co-administration is safe and immunogenic, but there are also several advantages. One, there's the convenience. There's fewer appointments for both the healthcare services and the individual. And in terms of side effects, it may mean that you might have side effects after having a vaccine, but this is kind of only after in one episode as opposed to 2 episodes after having 2 different vaccination appointments. And perhaps if we were given the vaccines in one arm versus 2, then that would have a less of an impact on our activities of daily living. In addition to this, there's timely coverage. We're usually in a hurry to ensure that we get as many people vaccinated as possible before the arrival of these seasonal pathogens. And if we start delaying the vaccines or spacing them out, then we might not be providing timely cover. And finally, there's the kind of chance to opportunistically offer vaccination, kind of as that bullet point that I drew your attention to earlier, that if someone's coming from one vaccine, then maybe we can use that time to talk to them about another vaccine and increase uptake. So that said, there are still some kind of unknowns. Firstly, how acceptable is vaccine co-administration to the public or people who we're offering the vaccine to? So on your screen there, you can see a newspaper article from 2021 in one of the most popular tabloid newspaper in the UK, where the resident GP received reports of people being knocked for six by a double dose. But overall, they wrote quite a balanced article and most people had no problem. And on your right, there was a tweet just from this season from a journalist working for The Economist, kind of asking what people think about having both vaccines together. Overall, the responses were very positive, but it did make me think then that we haven't quite got our comms right. So that's something that we need to consider. However, even if you do want to get your vaccine together, this might not always be possible because of supply chain. So in the UK, individual general practice surgeries or hospitals or pharmacies are responsible for ordering their own vaccines. We often get our flu vaccines at different times within our health system, and we get the flu vaccine at different times for the COVID-19 vaccine. So last September, I could have got the COVID-19 vaccine in the hospital, but I had to wait a month to get them both together. When we're planning these appointments, because we don't know about delivery, there may not be time available to give both vaccines together. And then finally, the vaccine kind of delivery infrastructure architecture has been influenced by the COVID-19 pandemic, where kind of prior to the pandemic, flu vaccine was delivered mainly in primary care to manage the early part of the pandemic. Mass vaccination centres, which is still operational, had to be set up. We need to think about how to bring those together. And of course, multiple vaccinations have been kind of quite normal in the childhood immunisation schedule for some time, but this hasn't always been the case. And this is a review article that really has looked at published work on provider and parental attitudes over the time where the number of vaccines in that immunisation schedule has increased. And you can see from the chart that it's gone from kind of just 2 in 1983 to 89 to kind of many more over those past few decades. And they looked at 44 articles, mainly from high-income countries. So in terms of parental attitudes, they found that parents were mostly happy to go with what their provider recommended, but when parents were asked whether they would be happy with an additional vaccine to the number that were currently being recommended, only the minority were really happy kind of with that. And most of the concerns were really about possible adverse events and stress on the immune system. But as the number of vaccines increased and recommendations changed, then parents' attitudes did change with time. It really highlights the importance of provider attitude. So it's really interesting then when looking at the provider attitudes, but actually there was some reluctance to give multiple injections at one time because people reported they thought it was too many and they were worried about the potential reactions. And there was really kind of an overestimate of the parental concerns. They thought parents might not bring children back in the future if multiple vaccinations were given. However, kind of deferring those vaccinations was actually associated with incomplete vaccination schedules. So it really highlights the importance of provider kind of confidence. And in terms of how we give vaccines, co-administration is really well established for children, and there's this really lovely picture in the Australian handbook that tells you exactly where to give these vaccines. And for older children and adults, we give them vaccines in the deltoid. And the CDC, kind of, this is probably an older diagram, say that ideally you should get one vaccine in each arm, but if you want both vaccines in one arm, then that's up to you. And they should be given on a 1 inch or 2.5 centimetres apart. And what's really interesting is that kind of 1 inch comes from some very old studies done in children looking at vaccination in the thigh, and there aren't really kind of one, those studies in adults, and two, there are no studies given them in both arms with kind of more modern vaccines. And you can see the caveat there from CDC that some flu vaccines cause more symptoms, so it's probably best to separate them. And there they're referring to the adjuvanted flu vaccines, but I would argue that our kind of more recent vaccines are more reactogenic than those previous ones. So we're all familiar with the reactions we had with the COVID-19 vaccines, and adjuvanted herpes zoster vaccine actually can cause kind of up to 9.4% of grade 3 reactions with the second dose. That's grade 3, so it impacts on your activities of daily living. And the most common side effect is myalgia, and it usually happens only for a short-lived period of time, but more data is needed on these newer combinations. I mean, that said, there are a lot of studies already looking at co-administration of influenza with actually non-seasonal vaccine types. So, you know, what is the relevance of this? And this really takes me back to the idea of opportunistic vaccination. So this is a graph looking at the uptake of the herpes zoster vaccine in the UK, and this is mainly with the use of the live attenuated vaccine, and it just shows that our uptake has increased over time. But importantly, kind of, it seems that the uptake or the offering of the herpes zoster vaccine was actually highest during influenza vaccine. So that's kind of based on this theory that if someone comes in for one vaccine, that's an opportunity to talk to them and offer them another vaccine. So kind of very finally, my take-home messages: co-administration of vaccines in adults is safe and immunogenic on the data that we have so far and the combinations that have been tested. There is the potential to reduce appointments, provide primary coverage, and increase uptake through opportunistic offers. But at the moment, there may be limits due to practical issues, and we need to know more about attitudes of providers and recipients, so we can give the support we need, and we need evidence for this, and kind of there are some evidence gaps in terms of the combinations that we can offer at the moment. Okay, so thank you for your time, and I'm very happy to take any questions.
The current data on co-administration of vaccines is the use of combinations of different types of vaccines. In other words, RNA and protein, RNA split vaccine, and so forth. And so would you expect the same sort of trend when you start to combine different types of targets with the same vaccine? In other words, if you sort of do a combination RNA vaccine, increasing the RNA content, increasing the components in those vaccines, for example, and so would you actually expect that you would get the same level of adverse events, or would you expect to have greater adverse events because of the current situation is that we are combining protein and RNA vaccines versus different types of vaccines?
And against the same virus or different viruses?
Different viruses, yeah, obviously.
Rajeka?
I think if the question is about live and killed and duration, I mean, my reading of the literature is that the literature is old. poorly put together and poorly reported. So I actually think that the data we have on that to answer that question are really inadequate.
Yep.
And in fact, if you look pragmatically, then it doesn't seem to be much of a problem, even though we talk a lot about, delays between vaccines. I think one of the issues, though, that may have been mentioned, but I think needs to be thought about is that small proportion of people have severe reactions. If you give multiple vaccines, how are you going to sort that out? And that's different to the question, but it bears upon the same issue: is how do you sort out what happens when something goes wrong in that small proportion, and particularly where it goes very badly wrong?
Yeah, I think that's a slightly data-free zone that, I don't think we know whether giving people more than one vaccine actually makes them a lot worse than if they would have the single vaccine, and maybe the reactions are almost really as bad as you would have got with the most reactogenic vaccine. And how, so the question is, how do you manage those side effects for those people with any vaccine?
Is there any literature on what to do if there is a severe, combination event? Have people reported their experience?
Yeah, I suppose there isn't any antidote that I'm aware of in that event. No.
In your experience, are these events so uncommon as to not, stop co-administration?
Yeah, I think they're less common than people just managing them, and I think they're quite variable, and I think they're difficult to predict which combinations and which years that an individual may have an increased response. We know that overall that reactogenicity doesn't correspond to immunogenicity, so there isn't really a good way to predict that. I think it's just about just in general, how do we support people through vaccination and can prevent side effects.
Thank you. Rajeka, there's another question from Alan Cheng, an ID physician at the Alfred Hospital.
Thanks for the great talk. I'm just going to paraphrase a question that was asked just before you came online. The combinations that we worry about, I guess, are 2 live vaccines or are 2 adjuvanted vaccines, and just interested in your clinical approach and whether you have, whether you're generally reluctant to do that or you tend to just push ahead with appropriate consent.
Yeah, so I think there's probably quite a lot of experience with 2 live vaccines given together, just in terms of maybe travel vaccines or in pediatric vaccines. I think the areas of uncertainty are now the combinations with adjuvanted vaccines and the mRNA vaccines, which are more reactogenic, but we have data now, with flu and the COVID-19 vaccines. But then an area that's lacking is with the recombinant shingles vaccine, which is adjuvanted alongside another adjuvanted vaccine. And certainly in the UK, that combination is not recommended routinely at the moment. So, but it's pragmatic to give it in one in each arm if you think that is your only opportunity and your patient is happy. So I think we can afford to be pragmatic, and I think the question moving forward is that can we give these in a single arm so that we can give 3 vaccines, because that is probably the emerging landscape if we don't have combination vaccines.
Hi, I have a question about information coming out of the US of risk of stroke that they've looked at in people that had COVID-19 vaccine and an adjuvanted influenza vaccine, and this was in the elderly. I think they've looked at it very closely and do not see a real signal, but they're not concerned about it, but they are going to watch it very closely going forward. And I wondered if you could comment on that in the UK.
I'm not aware of a signal like that in the UK, so I can't comment on that, and I'm not familiar with that US data. Is that something that you've seen in Australia?
The answer is no, that we're aware of. Rajeka, thank you. There was a comment from the floor that there hasn't been a signal in Australia, that the signal from America is just from one vaccine and hasn't been replicated. Thank you very much for your presentation, Rajeka.
Okay, thank you for inviting me to speak. Have a good evening.